series. This is a small contribution on the part of our AVMC and VMRF towards the medical fraternity to keep them updated. And on this platform that is created by the Scientific Society of AVMC, invites the eminent persons who have made some mark in their respective field, in the focused area. This is how we have here Dr. Biswajit to share his thoughts and expertise on this new immunotherapy and cellular therapy for oncology. We all know that cancer is the greatest killer of the mankind. So many things are coming. The moment we say immunotherapy, recently many controversies came about the immunotherapy, in the sense that the day when our Prime Minister declared that by many of these Ayush methods, immunotherapy you can enhance and thereby you can fight and arrest or stop or treat COVID, immediately took the attention of the world and so many controversies came in. Even the BBC Czech trial, they said that nothing of that kind, no evidence exists of that kind. So certainly, then I thought, this. One thing is, even though we say it new, this inoculation of something to treat something goes back to even Edward Jenner's time, when he tried to arrest smallpox by injecting some other virus, I think, So that is even quite long back. And this recent one has been recently, in this COVID also, what we noticed here, in some of our, even including our PGs also had measles during this time. And they're suffering from measles, and probably their, this one, what you call, the immune system is triggered or stimulated or something, whether it can afford. It's all a matter of time, and a lot of work is going on all these things, Even that Madagascar president declared some COVID-free drink in the school for everybody, and that is supposed to increase and the trial has been, WHO has set up a trial to test that free drink that is being distributed in Madagascar, and President has authorized that, So many things are coming. Certainly it's a wonderful topic that has been chosen to stimulate all of our cortexes, to just to know about that. And with these few words, I welcome you, Dr. Biswajit, and I request Professor Mahalakshmi to give an introduction about the speaker. Over to you, Mahalakshmi.
Okay. Thank you very much, sir. We kind of know Dr. Biswajit because we keep sending children to him for therapy. Sometimes for radiotherapy is being given in the regional cancer center and also the medical oncology. He has a very nice ward in JIPMER, and he keeps conducting programs, especially the Rose Day for cancer survivors and children. Like, that is on personal note. And just move over to, Dr. Biswajit has done his DM in medical oncology. He's also got his DMB, and he is an European certified medical oncologist. He specializes in hemato-oncology, including transplant, breast, and gastric malignancies. And his main area of research is in pharmacogenomics. He's very interested in biomarkers and drug trials for cancer. He's got over 50 publications in this particular field. And he's accomplished quite a lot in the last 10 years or so he's been practicing. He's got a travel fellowship for bone marrow transplant in Wisconsin. He has received international CML preceptorship for advanced training in Australia. He has got a translational workshop in Italy, ESMO 1 in 2016. And he has also been part of the Tata Memorial Cancer Institute workshops. He has also done an extramural funded project by the DST, and he received the Young Scientist Award, and this project got completed in 2016. So quite a bit of busy CV for Dr. Biswajit over the last years he has been practicing. And with this, I think a small introduction, I would request Dr. Biswajit to talk, and he will be illuminating our minds on about immunotherapy for cancer. So So what is the role and how it is going to go? We really look forward to this talk, sir. Over to you. I have passed on the presenter privileges.
Yeah,
You're on.
yeah, ma'am. I'll just share. Is my mic unmuted? Yeah, just.
Yes, sir. Yes,
Yeah,
you can go ahead.
Good afternoon. At the outset, I would like to thank the Dean, Dr. Vishnu Bhatt sir, the mentor, Dr. Mahalakshmi, and the entire scientific committee who has given this opportunity to discuss on some future frontiers. I think it's a series of webinar, and since my area is on cancer, so I thought the appropriate topic for a future frontier in cancer would be immunotherapy. In the last decade, there's lots happening in this field, and the survival of cancer has completely changed with this remarkable treatment approach. So I know it's a mixed population audience. We have probably students, faculty. So I've tried to keep the presentation as simple as possible. At the same time, hopefully I will give you evidence as well as to show that how immunotherapy and cellular therapy is going to change cancer treatment in the next 10 years. So my schema of presentation would include some few slides on basics of immune system. Then the next few slides would be to discuss on the different types of immunotherapy and cellular therapy, and those will be discussed under the heads of how it has evolved, the basics, and the impact on cancer survival and various adverse effects and tolerability of this treatment. So 4 major types of immunotherapy which I'll be discussing would be immune checkpoint inhibitors, adoptive T cell therapy, CAR T cell therapy, cancer vaccines. There are many more different kinds of immunotherapy, but these 4 will be the ones which I'll mainly be concentrating on. Then I'll also give you a few slides on what is happening in our country with respect to immunotherapy and cellular therapy, and what our future holds for in this treatment aspect. So coming to the basics of immune system, all of us know that lymph nodes are seen everywhere, like you get at your tonsils, adenoids, the thymus, the appendix, and Peyer's patches, as well as bone marrow and spleen are with the various organs of immune system. And immunity is basically of 2 types. It could be an adaptive immunity or an innate immunity. If it's an adaptive immunity, it can be a natural, that's how we get, either by passive through maternal antigens, or by active by different infections which we are prone to. Artificial is if we are transferring some kind of antibodies into our blood, then it could be an artificial immunity, and immunization, which is well known, which is also a kind of active immunization. But I'm not able to, yeah, right. So as we discussed, the immune system is natural or adaptive, and there are 3 different lines of defense for this immune system. The first line of defense is obviously the skin, mucous membrane secretions, and the gut flora. The second line is all our innate immune cells, the various inflammatory cells, the complementary activation systems, and antimicrobial substances. The third line, which is the most important, are the B cells and the T cells. The B cells which produce antibodies, and the T cells which are classified as either a helper T cells or a killer T cells. So when we are exposed to a particular antigen, this is how an response occurs. So we get an initial peak response, that is because of the antibody and an antibody peak and the effector T cell response. Subsequently, over a period of time, this comes down and a low level is maintained. Then in between, at any point of time when we get an inapparent reinfection, there will be again a small peak of this antibodies, which again will come, and a low level will be, a low sustained level will be prevalent. Then what happens is, over years, this part becomes a part of the memory cells, and then whenever we get a mild or inapparent infection, there is a spike of this antibody effector cells, which prevents us from major infections which we have already received before. Sorry, I'm not able to change the slide. Just a minute. Yeah. So with respect to the immunity cycle, this is something very important which we need to understand, which is called a cancer immunity cycle. So what happens is, this is a cancer cell, and this cancer cell releases antigens as this cancer cell dies. These antigens are picked up by something called the antigen presenting cells, or the dendritic cells, which then go into the lymph node, and then they are activated in the lymph node. And these cells are basically nothing but the activated T cells. Now these T cells, they traffic through the blood vessels and reach the tumor. Once they reach the tumor, then these T cells identify the MHC on the tumor cells, and get attached, the T cell gets attached to these tumors. And finally, the killing of the cancer cell occurs because of the T cells. So this is, then once the cancer cell dies, again it releases cancer antigens, which again has it's like a vicious cycle which occurs. So this is important, that at any point of time, our body is prone with so many different kinds of antigens, that this cycle is very, very important, and our immune system has to be strong to prevent the development of cancer. But then what happens is, the cancer cell sometimes becomes very clever. It tries to evade the immune system, so that the T cells do not recognize this cancer cells, and then the T cells become weak, and then the cancer cells proliferate. So before we understand how the division occurs, we need to understand that the most important part of an immune system is the T cell receptor, and the T cell receptors have two regions. One is a constant region, and another is a hypervariable region. Death of the cancer cells. Now, a structure of a T cell, and try to explain to you the different kinds of therapy which is available, then this becomes very, very important. So a T cell structure has two limbs. It has again I said it has a constant region and a variable region. The variable regions is the one which is responsible for the antigen binding site, and this can change depending on the antigens that are exposed to. They also contain a disulfide region, and these T cell receptors are also a part of it into the cytoplasm, which are connected to the CD3 receptors. So this structure, just remember this structure, because I'll again try to explain when we come to the different kinds of immunotherapy we see. Now we also must understand that the T cells has multiple receptors, and this which we can target to enhance the immune activity. So these receptors are of two types. They can be an activating receptor, or they can be an inhibitory receptor. The activating receptors, basically, the moment these receptors are activated, they will stimulate the T cell, and this T cell stimulation will result in the death of the cancer cell. Similarly, when the inhibitory receptors are activated, then the T cell stimulation is decreased, and then the cancer cell tries to escape from the kill. So of all these different kinds of receptors, we currently, the drugs which are available are basically targeting the CTLA4 and the PD1. So just remember this receptor, which is a CTLA4 receptor and a PD1 receptor, and they are all inhibitory receptors to the T cell. Also remember the CD28, which is again an activating receptor, and the importance of that I will tell you in the subsequent slides. So as we were discussing, that the immune system, the cancer cell tries to evade the immune system, and that's how the immune system fails and the cancer progresses. So what are the various mechanisms by which the evasion of the immune system occurs? Is one, by ineffective presentation of this tumor antigens to the immune system. So as I told you that the major histocompatibility complex expression on the tumor cells is very important for the T cells to recognize. So what the tumor cells do is they downregulate the MHC expression, thereby the T cells are not able to identify these tumor cells. And the second step is obviously that all these tumor cells the dendritic cells have to engulf and present it to the T cells. So unless this antigen presenting cell is not activated, the T cells cannot do anything. So the cancer cells, again, what do? They suppress the cells, which are called the Tregs. So the Tregs are nothing but T regulatory cells, and these Tregs actually have an inhibitory effect on the immune system. So the cancer secrete a lot of these Tregs and they inhibit the immune system. Then you have this something called the myeloid suppressor cells, and this myeloid dendritic suppressor cells also again suppress the immune system. The third mechanism by which the cancer cells escape is by release of different kinds of immunosuppressive factors. And the fourth is the T cell checkpoint dysregulation, which I said that there are some inhibitory receptors and there are some stimulatory receptors, and based on how this activation of this core receptors occur, the tumors either evade the immune system. So cancer immunosurveillance is very, very important. As I told you that even in a normal human being, generally this immunosurveillance for cancer always is there. When the cancer cells escape the immunosurveillance, that is the time when the patient develops a cancer, a person develops a cancer, or the cancer progresses. And to show this, there is a data saying that interferon as well as lymphocytes prevent primary tumor development and shape the tumor immunogenicity. And this classical example is your retroviral diseases, where you know that the immune system is completely hit, and we know that there is an increased risk of cancers in these patients. Classical cancers like Kaposi sarcomas and non-Hodgkin's lymphomas are seen in these patients. Now, all cancers are not similar. So all cancers do not have the same immunogenicity. You should understand that. And the different cancer cells have different amount of somatic mutations. It is known that if you have more number of mutations, the cancer is likely to be more immunogenic. So if you actually if you see this picture, that there are some cancers like melanoma, lung cancer, bladder cancer. These are the cancers which probably respond very well to immunotherapy. Now, what are the important features that make immunotherapy an attractive alternative for cancer treatment? These treatments are very specific. They are very less cytotoxic, unlike the conventional therapy, which actually, when you give a conventional chemotherapy drug, it affects all the cells in the body, normal cells, thereby causing myelotoxicity, other organ toxicity. So in that way, immunotherapies are less cytotoxic, they are more specific, and they have long-term memory responses, because of these tumors actually relapse. And one of the reasons why they relapse is that the effective treatment, after some time we stop, and then the tumor relapses. But the immunotherapy, by its long-term memory responses, you will see that the graphs actually tend to flatten out. So though a very few number of patients respond to this immunotherapy, but the good part is if they respond, then you actually get a graph which is flat. It does not go down. So if the patient responds to the tumor, then the chances that he relapses are very, very less. And then I have also discussed about the importance of immunosurveillance preventing the activation of the cancer. Now, based on the inflammatory response, the tumors are classified into two groups. One is the hot tumors, the second is the cold tumors. Why this is important is, why this is important is the hot tumors, the pre-existing immunity is very high. So it's expected that if you give any immunotherapy in this set of patients, they will respond very well to the immunotherapy. But there are some tumors which are completely cold. They do not have immune response at all. These tumors may not respond very well to immunotherapy. So one way is to make these cold tumors into hot tumors. So how we can make cold tumors into hot tumors? You could actually give cytotoxic chemotherapy, or you could give radiation. So all these methods can make cold tumors into hot tumors, and then you treat them with immunotherapy. Now, so for hot tumors, immune checkpoint inhibitors and cytokines work very, very well. So again, cold tumors, obviously the immune checkpoint inhibitors will not work, and that is the place where probably vaccines and other antibodies might work. So we discussed all this. So why there was a necessity for development of immunotherapy? We know from 30, 40, 50 years, we have lots of cytotoxic drugs. Cancer treatment is improving, but then we are still not able to cure some of these cancers. So if you see this slide, you can see that cancer, solid tumors like pancreas, liver, esophagus, lung, brain still have a very, very poor survival, 5-year survival rates. Also, one should understand this. There's this disease called melanoma, which we generally is not very common in our country, but their survival seems to be very, very good if they present very early. If you present at stage 1 and 2, then you are almost completely cured. But look at patients who present with a stage 4 tumor. They have a response rate, they have a survival of less than 20%. So it's important to understand that all cancers are not the same. Even if some cancers are doing well, the patients who are metastatic and have advanced presentation, they don't do very well with the current treatment which is available. Now, one other example is in leukemias. We know that ALL treatment over the period of decades have dramatically improved in survival. Look at the survival in 1968 and 70. Hardly 10% of the patients were getting cured. Look at the survival in 2006, 2009. You almost have 95%. This graph is very good for a pediatric ALL, but for an adult ALL, you will not get this. You might get the curve somewhere in between this. And also, you must understand that in a country of ours, our survival rates lie somewhere in this region, and we are not able to achieve somewhere around 90% or above. The reasons for that have been plenty. The reasons that genetically our tumors are completely different. Probably there are other related issues that we are not able to reach this survival. Now you should also understand that just look at the survival if the patient develops a relapse after the treatment. So in our situation, almost 30% of our patients relapse. So let's say if this is a relapsed patient and you start treatment, all your patients will be probably dead by 1 year with the current available treatment. Maybe if you transplant them, maybe you might get somewhere around 30%. But otherwise, the survivals are very, very poor. Now, the cancer immunotherapy is nothing but it's a therapy aimed to enhance the power of the host immune system for treatment of malignancy. And the goals are 3. One, that we require a very good anti-tumor response. We want to reduce the immunosuppression so that the cancer cells will not escape. We also want that there is an increase in the immunogenicity of the tumors. So historically, we can see that as our dean also said that these type of treatments have been there for centuries. And the first probable treatment was in 1898, which is called as the Scoliosis Toxin, which I'll show in the next slides how they actually treated cancer patients with this toxin. But over a period of time, in 1985, the first probable immunotherapy which had a breakthrough was an interleukin-2. This interleukin-2 was initially used for renal cell carcinoma, where metastatic renal cell carcinoma, the survivals were less than 10%. And with all chemo, and none of the chemotherapy drugs actually worked. And interleukin-2 at that point of time, there were almost 20% of the patients who actually responded, and those patients who responded are completely cured of the disease. Remarkable drug, but the problem was it was associated with a lot of toxicity, so it actually did not make it too much into the clinics. Then in 1995, we have this wonderful monoclonal antibodies which started coming up, and the first monoclonal antibody was rituximab, which is a monoclonal antibody against the CD20 of the lymphoma cells. So this drug dramatically improved survival in patients with lymphoma. Subsequently, in 1998, there was another monoclonal antibody which was trastuzumab, and this was basically an HER2 monoclonal antibody which was used for the treatment of breast cancer. Subsequent to this, there have been so many and newer monoclonal antibodies which have developed in the recent time. So as I was telling you that Scoliosis Toxin was way off, and then subsequently there was something allogeneic bone marrow transplant, which we still, and this is the only probable treatment which actually cures some of the tumors which relapse, but these procedures have high complications. You have a transplant related mortality anywhere between 10% to 20% depending on the center, and they have long-term problems like GVHD, which is called as a graft versus host disease, where the donor cells which we have infused actually go and kill the recipient cells and damage all the recipient organs and result in severe morbidity and mortality. Still we use this therapy. They are not very specific, lot of side effects, lot of issues to do, but this is also a kind of immunotherapy. The next set is I discussed already, which is the interleukin and interleukin therapy, and then we have the adoptive T cell therapies. So the Scoliosis toxin was a very interesting story. So this toxin, basically it was a cocktail of toxins from Streptococcus and Serratia. William Coley had actually prepared a cocktail of this and injected, and the tumor actually disappeared. So William Coley was basically a surgical oncologist, and this was his first patient whom he injected, and this tumor completely disappeared. It was a case of a sarcoma. So unfortunately, it was not long lasting, and within 6 to 8 months, the disease came back, and then the patient died. This is again a paper when Coley's toxins were used before 1940s. You can see almost they tried it on all different kinds of malignancies. So what is the interaction between a cancer cell and the immune system? This is very important, and this is called a cancer immunoediting. This principle is very important to understand. Why? Because there could be 3 possibilities when the cancer cell and the immune system join. So one possibility is elimination of the cancer cells. So if the immune system is very strong, then it's going to destroy the cancer cells. The cancer is completely eliminated. Second possibility is equilibrium, and this equilibrium happens when the cancer cell and the immune system balance each other, and this results in tumor dormancy. And the third one is something called escape, which I already said, that the cancer cell escape the immune system and result in a progression of the cancer cells. So this is how an interaction occurs, and we need to understand this principle. So I told you about this high dose interleukin-2. So this was the responses. Look at the responses in melanoma. There were 182 patients, but there were 12 patients who had a complete response. I understand that these numbers are small, but even these 12 patients, they had a complete CR and they had a survival almost of 90%. Otherwise, this was never heard of. So if you can just see these patients who actually responded to the interleukin-2 and developed a CR. Look at their survival, excellent survival. So the next part of my topic would be on to just broadly classify the kinds of cancer immunotherapy available. They can be divided into two groups. One is the passive immunotherapy and an active immunotherapy. The passive immunotherapies are the antibody therapies, which I exactly told you about the monoclonal antibodies. These monoclonal antibodies can be isolated or conjugated. They can be bispecific monoclonal antibodies, which is otherwise called as BiTE therapy. So it's called bispecific T cell engager therapy. Next, you have active immunotherapy, which is by cytokine therapy, which is by interferon and interleukin. Then you have the immune checkpoint inhibitors, which are the PD-1, PD-L1 inhibitors and the CTLA-4 inhibitors. This I had marked when I showed you the T cell different kinds of receptors. These are the negative receptors or the inhibitory receptors, and there are drugs now available to block this inhibitory receptors. Then you have the third group, which is the cellular immunotherapy, which is tumor infiltrating lymphocyte. Then something called the engineered T cell receptors and chimeric antigen receptor therapy. The CAR T cell is again something which is very new in the last 7 to 8 years. Again, I will show you data that how this is dramatically improved survival in some few malignancies. Again, you have natural killer cell therapy, dendritic cell therapy, and then vaccines. So of all this, I would be concentrating on antibody therapy, on the immune checkpoint inhibitors, on the CAR T cells, and vaccines. And the newer areas of research which is ongoing is on anti-CD47 therapy, anti-GD2 antibodies, and other immune checkpoints. I have discussed only 2 immune checkpoints, but there are many of other immune checkpoints which have been tried out. Then other viruses, polysaccharides, and neoantigens. So the first area is the monoclonal antibodies, and all this was feasible because of something called as Hybridoma Technology, and for which Kohler and Milston actually received a Nobel Prize in 1984 for developing this technology, which is called the Hybridoma Technology. So what does this technology do is that these mouse are injected with the cancer antigens, and then the spleen is cut, removed, and the splenic cells are separated, to which the myeloma cells are fused. Why myeloma cells? Because they contain immunoglobulins. So these are fused, and then hybridoma is, and because of this hybridoma technique, they are the antigen as well as the antibody reaction occurs, and as a result of which they are the hybridoma occurs, and then you culture this into media and expand them, and from that you harvest the monoclonal antibodies, and these monoclonal antibodies target the cancer cells and kill them. So you have different kinds of monoclonal antibodies available in the market. So they are basically of 4 types. It could be a completely mouse related monoclonal antibody. It could be chimeric, where the majority is from the human, but at the same time you have some from the mouse. It could be a humanized, where more than 90% is from the human, and probably 10% are from the mouse. And if it's human, it's completely a human which does not have any of this mouse. So the immunogenicity decreases as you use the type of monoclonal antibodies. It's also important to understand that if you use, if you have a lot of immunogenicity, then the body's immune system will damage, and you will start developing an antibody to this. So it may not be effective. Whereas in human, since the immunogenicity is so low, that the chances of development of antibodies is going to be very, very less. How does this monoclonal antibody therapy work? If it's so there could be Okay. I'm not okay. Right. So the monoclonal antibodies are how does it? What are the different kinds of monoclonal antibodies? We could just have a simple single monoclonal antibody, or you could have a monoclonal antibody which can have immunoconjugates. For example, this is a simple monoclonal antibody. If you attach a radionuclide, or you can attach a cytokine or an immunotoxin, then it becomes an immunoconjugate. So the antibody also makes an attack on the tumor cells. At the same time, the radionuclide and other things also attack the adjacent cells. So it's something called as the crossfire effect. So this cells also hit the other cells which are closely associated with the tumor cells. Then you have a third method is the multi-system targeting, where you have the bispecific monoclonal antibodies, where you have two different antibodies combined. So these are the different types of monoclonal antibodies. I am not able to change ones.
Sir, your annotation is on. Can you?
Yeah, I'm not able to switch off that.
You can stop sharing and come back, sir.
I think now it's okay. Should go ahead. Oh no, it's not. Okay, I'll get back again. Sorry for that. So I think it's visible. Madam, it's visible, no?
Yeah. Yeah, it is visible,
Yeah.
sir.
Okay.
Nice.
Yeah.
Please go
Right.
ahead.
Yeah. So yeah, I'm very sorry for that short break. So the next slide would be on how do this monoclonal antibodies work. So these monoclonal antibodies work one by activating the macrophages, and this is by antibody dependent cellular phagocytosis. Then they could also activate an NK cell, antibody dependent cell mediated cytotoxicity. They could enhance the complement dependent cytotoxicity, and which will result in cell death. So three main mechanisms. One is by phagocytosis, two by NK cell, and three by the complementary activation. Now these are some of the few monoclonal antibodies which have been approved recently, and there are more than 70 to 100 new monoclonal antibodies in the pipeline. And you can see the various monoclonal antibodies which have been all these are available in the country: bevacizumab, cetuximab, panitumumab, and daratumumab. So almost like we have some 7 to 8 monoclonal antibodies which are currently available in the country. Now, so as I said, that what is the impact of all these monoclonal antibodies on the survival? Look at the survival in lymphomas. Pre-rituximab era, the median survival is hardly 2 years. And here the median survival has not even reached in the post-rituximab era. So look at the gap between the two curves. It's so wide apart. Similar with the overall survival. Look at the monoclonal antibody with trastuzumab. Again, the same. Your curves are so wide apart with an excellent survival in patients who are HER2 positive breast cancer. Previously, HER2 breast cancers, the survival used to be very, very poor. And with trastuzumab, the survivals have dramatically improved. This is another drug which is in pipeline, not available in the country, but it's FDA approved in US. And this is an exciting drug which is a kind of a bispecific monoclonal antibody. So these bispecific T cells have one, it has a CD3 receptor, and also it has a monoclonal antibody. So it also activates the T cells. At the same time, the receptor also activates the tumor, also kills the tumor cells. So the drug which is called as the blinatumomab, and this drug again in a relapse situation where the survival is so very poor with chemotherapy, they have shown sustained response, but that doesn't seem to be a everlasting response. That's the problem with monoclonal antibodies. Actually, you don't get that flat kind of curve with these monoclonal antibodies. So these responses are enough for us to take up for further treatment. Like let's say I want to take up a patient for a transplant and I want him to be in CR, then these drugs act as a bridge to the main procedure. So this was first approved by FDA in relapsed and refractory ALL, and the various side effects of this monoclonal antibodies. The most common side effect is infusional reaction, something called as cytokine release syndrome. So when you infuse them, there can be a very massive cytokine release resulting in severe respiratory issues, almost similar to something which they are saying about COVID, when the COVID can cause a very bad cytokine release syndrome. Immune system alterations with respect to that, common infections, the patients are prone to infections. Opportunistic infections can reactivate. A classical example of hepatitis infection, tuberculosis can get reactivated. You could also get an autoimmune response phenomena where you could get immune thrombocytopenic purpura and thyroiditis. And also there could be induction of neutralizing antibodies. The next exciting area after monoclonal antibodies has been the immune checkpoint inhibitors. And these in the last 5 or 6 years changed the way we treat solid tumors. So the immune checkpoints again are two major areas which are currently, one is the PD-1 pathway and other one is the CTLA-4 pathway. These are basically the co-inhibitory receptors which we saw on the T cells. So in short, I'll try to just explain how does this work. So this is the CTLA-4. This is the tumor cell. On the tumor cell, this is a receptor called the B7 receptor. This B7 receptor either binds to a CD28 or a CTLA-4. So these are the two homologous thing which the B7 attaches to. Now what happens is that CD28 is a stimulatory one, CTLA-4 is a inhibitory one. So in cancer, what happens is that there is an overexpression of CTLA-4. So what happens is this cancer cells stimulate the T cells to produce more CTLA-4. So if the CTLA-4 overexpression occurs, when they bind to the B7, then there is an inhibition of the proliferation of the, there is an inhibition of the T cells. So the T cells are not able to kill the tumor cells. Now what happens if you give an anti-CTLA-4 therapy? So when an anti-CTLA-4 therapy is given, these antibodies go and bind with the CTLA-4. Thereby, the CTLA-4 is no longer able to bind with the B7, and the CD28 now becomes free. The CD28 is a co-stimulatory receptor, and this, once they bind, it stimulates the T cells, and the T cells in return activates and kills the tumor cells. So that's how a CTLA-4 works, inhibitor works. What happens to PD-1? So again, this PD-1 is again found on the T cells, and a ligand, PD-L1 ligand, is found on the tumor cells. Now in a tumor, in normal antigens, the PD-L1 is not that much expressed, but in tumor cells, the PD-L1 expressions are very, very high. So the moment there is a lot of PD-L1 expression, the PD1 goes and binds, and the binding of the PDL1 and the PD of the T cells, and the T cells are not able to proliferate. Now, if you give a drug which can either block the PD1, which is called an anti-PD1 receptor blockade, or an antibody, monoclonal antibody against the PD1, or you block the ligand. So there is also monoclonal antibodies which can bind against the PDL1. Now, if this binds, then the PDL1 and the PD1 cannot interact, and then this inhibition goes off. So this inhibition goes off, then the T cell gets activated and then kills the tumor cells. So this is in short how the CTLA4 and the PD1 inhibitors work. And again, you have another Nobel Prize group, another group of people who actually won the Nobel Prize in 2018. This was James P. Allison and Honjo. And Honjo was actually responsible for the identification of a PD1 receptor. And he has done a lot of work on this PD1. So how this checkpoint inhibitors actually work, how did they evolve? In 1980, the CTLA4 was cloned, and in 1990s, the PD1 was described. Then by 2000, the PDL1 was described, and probably the drugs got approved somewhere in 2014-15. So you can see that it almost took 25 years by the time we actually identified the target, but then the drug got approved almost after 25 years. So these are the drugs which are currently available. You could have a PD1 inhibitor, which is nivolumab, pembrolizumab. These two drugs are available in the country now. Then you have a PDL1 inhibitor. Again, this is also available, atezolizumab, and this drug also are currently available. And if you see from 2014, look at this slide is so complicated, but look at the numbers of approvals which they have got. There's so many malignancies covering almost all different kinds of malignancies at different indications where the drug has got approved. So these are the various malignancies. There's not one malignancy where it does not work. Most of the malignancies it works, and this numbers are increasing over a period of time. So this is the impact. This slide is very important. Just look at this slide. Melanoma stage 4 before 2011. Look at the survival, hardly 12 months. Look at the survival with pembrolizumab and ipilimumab. You have a flat curve at 90%. I mean, this is like unheard of responses in melanoma. And melanoma is one disease where none of the cytotoxic chemotherapy actually have ever worked. Look at the treatments in non-small cell lung cancer. This is the docetaxel arm. Look at the PD1 inhibitor. There's so much of improvement in the survival, almost doubling of the survival. This is again another pembrolizumab, which is a kind of PDL1 inhibitor, and look at the survival again here. So one must understand is that everybody is not going to respond to the immune checkpoint inhibitors. So the issue is that, so if you actually give 100 patients an immune checkpoint inhibitor, only 20% of them will actually respond, but those 20% who respond will be completely cured of the disease and will do very well. So currently people are looking at identification of biomarkers. If we could identify which patients actually this therapy works, so that we can actually cut down the cost and not give unnecessary toxicity to the rest 80% of the patients. So some of these biomarkers have been on, one is the PDL1, which is the most commonly used biomarker. So the PDL1, it can be studied by immunohistochemistry on the tumor cells, and depending on the percentage, the responses are there. But again, there is so much of tumor heterogeneity that it's very difficult, that some places the PDL1 may not be expressed, but still the tumor responds to the immunotherapy, and there are places where the PDL1 is well expressed but does not respond to immunotherapy. So the PDL1 is still not a very good biomarker, but that's what we have currently, and people are still looking at how to improve the different kinds of biomarkers. There's something called tumor infiltrating lymphocytes, which is a very good biomarker for patients with triple negative breast cancer where they have identified. There is something called mutational burden, tumor mutational burden. So if you have a tumor mutational burden of more than 10, then they say that those are the tumors which will probably respond to immune inhibitors. Now, with the development of this immune inhibitors and this targeted drugs, newer kinds of concepts are coming up, something called as tissue agnostic therapy. So what you understand by tissue agnostic therapy is, previously they used to identify one particular drug, then test it in one malignancy, then you check it in another malignancy. So now they are looking at targets like the MSI, microsatellite unstable tumors, mutations. And if you have this kind of mutations, these mutations can be present across all tumor subtypes. And if they have these kinds of mutations, they're generally immune rich tumors. And if these patients, you give them immunotherapy, irrespective of where from the cancer is arising, they have a dramatic response. And the FDA 2 years back has given an approval saying that any patient who has an MSI high mutation, irrespective of the tumor, you can try out this drug. So this is again a new concept of tissue agnostic therapy which is coming up. So what's happening in medicine clinical trials? The trials are changing. Previously, we were doing kind of umbrella trials where you actually look at one mutation. Classical example, lung mutation. You have an EGFR mutation in a lung, then you test one drug. Let's say Geftinib is a drug which is approved for EGFR mutation in the lung. Then you test drug 2, which is an ALK inhibitor. But now with this immunotherapy coming up, you look at one mutation. The classical example I gave you is an MSI high across all the tumors, and test one drug, which is pembrolizumab, and there will be a blanket approval on all tumors which has MSI high. So this is just one example. There are multiple other drugs like the BRAF inhibitors and all, which are coming up in the similar model. Now, with the advent of this immunotherapy, the immune checkpoint inhibitors, and completely new spectrum of adverse events were seen. So as oncologists, we are still not very tuned to this kinds of side effects, because most of the side effects are related to the endocrine system, and they cause a lot of issues on the endocrine system, resulting in starting from hypophysitis to hypothyroidism to hypoadrenalism. And managing this toxicities is a completely different challenge. And apart from that, you have other immune related side effects, like you could have rashes, you could have inflammatory things, you could have pneumonitis, you can have enterocolitis, and all this management requires a consolidated team of people from immunology, from endocrinology, to help us in management of this toxicity. The good part is only if some patients develop these reactions, and if they develop these adverse effects, most of them are reversible by using immunosuppression or by using steroids. So they are not like the classical cytotoxic drugs where you have myelotoxicity and neutropenia, fever and all this, but these are a different set of toxicities and mostly manageable toxicity. One concept has come up with this is pseudo progression, which is an important thing which we need to understand, that when we start immunotherapy, there will be a flare of these T cells, and it will look like the tumor size is actually increasing, and it's because of this flare. And many times we will stop. If it would have been chemotherapy, we would stop therapy because it's progressing. But because it's this immune system, the immune therapies are like this, that you actually need to continue, and then you suddenly will start seeing the tumors to shrink. So the standard response criteria which we use for CT scan using RECIST criteria cannot be used in when you are treating this with this therapy. So there are some different kinds of response criteria used for this. Okay, so that's part. That's the end of the immune. So monoclonal antibodies I have covered. I have covered the. Now we will go to something different, which is cellular therapy. This is another very interesting area which is developing, not available in the country. and this is called an adoptive cellular therapy. So what you do in an adoptive cellular therapy is you take out lymphocytes, then you activate them. You activate them, and how do you activate them? Is that once you activate these T cells, the T cells can be engineered, and one method of engineering the T cell is by using a chimeric antigen receptor. So I'll just show in the subsequent slides how the chimeric antigen receptors are actually engineered, and then they are expanded, then put back into the host patient. So this is engineered. If you don't engineer and do it in a natural way of expansion, then what you need to do is you take the tumor cells. From the tumor cells, you isolate the tumor infiltrating lymphocytes, expand them, and infuse them. So this is a natural way of doing it. This is an engineered way of doing it. So there are two different aspects of adoptive cellular therapy. So if you see the cellular therapies over the years, you see till 2010 hardly any activity was going on, but since the development of the immunotherapy, especially the immune checkpoints, and the understanding of the T cells better, from 2012 to 2019 there has been an expansion of cellular therapies, especially of the chimeric antigen T cell, which is the engineered T cell therapy. So as I told you, there are two ways, which is naturally occurring and one is genetically engineered. So, and naturally occurring is you take the tumor, isolate the T TILs, expand it, give it to them, and you can see that this TILs, after getting expanded, would go back into the body and then kill the cancer cells better. So this is how the whole treatment is given. You give lots of immunosuppressive therapy like cyclophosphamide, fludarabine, so that your body immunity is gone down. Before this, you would have isolated your TILs, then you give your TILs, and then wait for the recovery to occur, and then the TILs go and kill the cells. This is one example of how the tumor infiltrating lymphocytes work in melanoma. You can see that the survivals are there, but the problem with all these tumor infiltrating lymphocytes are that they are not long standing, and they are not the duration of response is not very, very good, and works very well only in tumors which are highly immunogenic. Only then it works. So then people came out with this engineered technique, which is called the CAR T cell therapy, which is otherwise called the chimeric antigen receptor T cell therapy. So this is also an interesting story how they developed this. This girl, who is now actually 17 years old, at the age of 5 or 6 years, Emily Whitefield had developed a cancer, which was an acute lymphoblastic leukemia. She got a relapse of the disease. I showed you before that relapse ALLs do very, very, very badly, survivals of less than a year or so. So she did not have any treatment available. At that point of time, Dr. Carl June was actually experimenting on this CAR T cells, which is the chimeric antigen receptor T cells. And in fact, if you see in the beginning part, he actually did not get funding for this. So the National Cancer Institute did not give funding for his research. And the person was actually known to Dr. Carl. So she agreed to undergo his therapy. So they gave the first CAR T cell to this patient, Emily Whitefield, and her tumor completely disappeared, and she is in complete remission, and she is doing well after 7 years. And now she was 6-7 years, now she's 17 years. That was the first report of how this CAR T cell therapy can actually change the outcomes in leukemias. So how these CAR T cells are prepared? This CAR T cells are prepared by what you do. The patient, a leukapheresis is done. That is basically you collect the cells, then you enrich these T cells. After that, using a viral vector, you introduce a chimeric antigen receptor into the RNA, then you proliferate them, and then you give it back to the patient. So this is what, in short, the leukapheresis occurs. The manufacturing involves three parts. One is isolate and activate the T cells. Then you engineer the T cells by using a viral vector. Sorry. and then you expand them and then infuse them. So the CAR T cells, this is a normal T cell receptor, which I already explained before. It has two parts. It has a variable constant region and a variable region. The variable region is the antigen part. So in the first generation CAR, now we have different CARs. We have first generation CAR, second generation CAR, and third generation CAR. The first generation CAR, which is, this is the variable region. The variable region is completely engineered so that it attaches to the cancer cell. So you could have, let's say, example is a ALL. You have a CD20 receptor on an ALL cell. So this is engineered to attach itself to a CD20 cell. At the same time, these are the co-stimulatory molecules. So you actually engineer, because the co-stimulatory molecules are not there, or sometimes they're absent, or they're non-functional. So you actually add co-stimulatory molecules. So if you add one co-stimulatory molecule, then it's a second generation CAR. If you add two co-stimulatory molecules, then it's a third generation CAR. And this whole engineered thing is then, by using a virus, it is transfected into the T cell, and then these T cells are expanded, and then it is given to the patient. So this is how it works. So this is the T cell. This part is the engineered part of the T cell, which contains the CD3 domain, which is the receptor domain. This is the CD28, which I said as the co-stimulatory. So this is the second generation CAR. And this is the antibody, which goes and attaches to the CD19 cells. So you actually have developed a wonderful, strong weapon, T cell weapon, which goes and actually kills all the CD19 B lymphoma cells. So the CAR T cell therapy is very, very expensive. In US, it costs around 4 crores to undergo one session of a CAR T cell therapy. So multiple centers have been trying, and also it's important that for every patient, you actually need to do individualized CAR T cell therapy. So all this involves cost, and there are 365 ongoing studies on CAR T cell therapy, and we can see that Asia, especially China and US, is leading on this CAR T cell therapy. In fact, China is the leading country with respect to CAR T cell therapy. And most of the CAR T cell therapies, currently 2 CAR T cell therapies have been approved, one for ALL and one for DLBCL. And majority of the CAR T cell therapies which are ongoing trials are on the hematological malignancies. And solid tumor, the CAR T cells are evolving, not yet gone into the phase 2 clinical trials, are still evolving. Obviously, there are lots of other modifications which are being done to the CAR T cells. What are the advantages of the CAR T cell therapy? It targets specifically, so that cytotoxic nature is less. They are HLA independent. This classical is for bone marrow transplant. You know that for a allogenic bone marrow transplant, you need to have a HLA match. If you do not have a HLA match, your survival, your toxicities of the transplant are very high. But the CAR T cell does not require a HLA match at all. They do not develop a GVHD, and the drawbacks of a CAR T cell is the 4 cytotoxicity. So one is the cytokine release syndrome, again, which is quite high with CAR T cell therapy. And actually there are drugs now. Tocilizumab can be used for control of cytokine release syndrome, tumor lysis syndrome, which also can be taken care of. These are CAR T cell related encephalopathic syndromes. You could also get hemophagocytic syndromes. So these are some of the 4 side effects which are common to this CAR T cells. The main drawback is on individualized manufacturing process. It's very complicated because we are having here manipulation. It requires a lot of purity and isolation of when you're doing this manufacturing process. So this is what I was saying you in ALL. Look at the survivals. If they're adult ALL, the survivals are very, very poor. And this was this was the first CAR T cell, which is Chimera, and this was approved. And look at the overall survival and the EFS. You saw the previous drawing where the survivals were here, and now you see a survival here. So overall response rates of 81%, with DLBCL 52%. Median EFS has not reached in ALL, and 65% in DLBCL, which is never heard of previously. this is in pediatric population. Again, you have when we have this available therapy. Again, you have it in B-cell lymphomas. Again, the CAR T cells have been approved for lymphomas, and you have various toxicities related to that. The CAR T cells generally require a multidisciplinary approach and cannot be done with a single person. The last part of my talk is on cancer vaccines. Not many slides, because the cancer vaccines have not been have been there for quite some time, but have not been very, very effective. We know that two types of cancer vaccines are there. One is prophylactic, therapeutic. The prophylactic ones, the classical one is the HPV, which is completely different. We are not discussing prophylactic here. We are discussing on therapeutic vaccines. And different targets include a tumor cell vaccine, a dendritic cell vaccine, peptide cell vaccine, genetic vaccines, and different kinds of vaccines. Vaccines, in short, to understand, you have an autologous vaccine where you resect the tumor, then you add an adjuvant and prepare a vaccine and then inject it back. In an allogenic vaccine, you actually take it from a human tumor cell lines and then modify and then you inject it. Then you have a dendritic cell vaccine where you actually take the monocytes, give them GM-CSF, make them into immature dendritic cells, and then this dendritic cells you stimulate them with cytokines and then inject it back into the patient. So one example of a vaccine which has actually worked in the last 20 years or 30 years is Sipuleucel, which is for prostate cancer, and this is a kind of dendritic cell vaccine. And if you look at the survival again, not a very great survival, not like the ones which I showed you before, but some better improvement in patients who received this vaccines. So cancer vaccines, the problems are immune reaction against vaccine is there. What happens is subsequently the immune reaction occurs against the vaccine, but not the tumor. Then antigens are different for each tumor, so difficult to make so many different new antigen vaccines. And most of them involve autologous tumor cells. So for every patient, we need to take out separately. And then there is a lot of suppression by the tumor microenvironment. And the vaccines alone are unlikely to have a major effect in the absence of immune checkpoint inhibitor. I have another 4-5 slides to go. So the current scenario in interesting part of the talk will be that rituximab, I said, is available in the country. We are able to give now to almost 95% of our patients this drug, and remarkable improvement in survival. Herceptin, again, trastuzumab, with available generics over the last 2 years, 3 years, almost 75% of the patients are able to get this drug. These are the two immune checkpoint inhibitors which are currently approved and available in the country, pembrolizumab and nivolumab. Expensive therapy. A course of 1 year therapy will cost anywhere between 24 lakhs to 30 lakhs. These two drugs. The CAR T cells, where are we with regard to CAR T cells? The CAR T cells of the CAR T cell, they have done the base work, and now they are going to start human trials soon. So they are expecting that the cost of this would come down to around 20 to 30 lakhs. So outside it's almost 4 crores, maybe in 30 lakhs. So 5 years down, we might have CAR T cell therapy available in the country. With respect to cervical vaccine, this is a lot of work has been done by Dr. Rajkumar from Adair Cancer Institute, where I actually did my DM. So he has been doing phase 1, phase 2 clinical trials on this HPV related cervical cancer. Future of cancer treatment, look at the number of clinical trials which are ongoing with all this PD-L1 inhibitors. There are probably more than 1,000 clinical trials going on. With respect to cell therapy for solid tumors, the tumor infiltrating lymphocyte therapy is one which should expand beyond melanoma. Hopefully in future it will happen. Then novel developments in gene modification, which will probably reduce the toxicity with CAR T cells, make the things more cheaper and easy to produce. And future of the CAR T cells, hopefully if the allogenic CAR T cells develop from cell lines, then it becomes very easy. Then you actually, on the shelf, off the shelf, you will have the CAR T cells. Then there are 4th generation CAR T cells in development, which includes also cytokines. There are other technologies, gene technologies, and then combination therapies. Most of these CAR T cells are for hematological malignancies. So the take-home message, this will be my last slide. So the take-home message for everyone is that immune system, major player in control and eradication of tumor, which we actually knew, but there was no effective therapy available till 5 to 7 years back. Immune checkpoint inhibitors have made a dramatic change in the treatment outcomes, dramatic response and survival in malignancies, which are having a dismal survival. But we are still learning on which patients will respond, so we are looking for ideal biomarker. CAR T cells, beautiful concept for cellular therapy with promising cure in relapse ALL. Cost is the limiting factor. Hopefully in the next 5 years down, we'll have a CAR T cell in the country. Vaccines, again, mixed results, and hopefully and come by immunotherapy approach will be the way forward. Again, I like to thank everyone for patiently listening to me. Thank you.
Thank you, Dr. Biswajit. Actually, in our entire MPS, most of us know, the most fascinating book to read was Riot's Immunology, like which will take you to some very fancy lands and a lot of innovative thinking and going from hybridoma to CAR T cells.
I'm not able to hear. Just a minute, ma'am. Yeah.
Yeah. Am I audible? Hello? Am I audible?
Your voice is breaking. I'm sorry. Just a minute. Let me stop sharing, I think. Yeah, audible, ma'am. Yeah, audible, ma'am.
Okay. So the most fascinating book to read was Riot's Immunology. And this was like a crash course in Riot's Immunology, juxtaposed to 2020. So that was the presentation and the flavor of the day. And the most impressive thing about the entire presentation was like Bernard Fisher keeps telling, no, in God we trust. All others need to have data. Thank you for showing data to support all your statements, what you have made. So we have quite a few questions from audience, and we try to take at least this question.
Yeah.
I hope you don't mind.
Yeah, please.
Yeah. So the first and foremost question comes from Dr. Vishnu Bhatt. And sir wants to know that whether this immunotherapy can be used for induction therapy, or is it only for maintenance? Is there any specific duration you continue this therapy? How do you assess the response to treatment? Because if you say that the classical CT findings cannot be used for assessing response to therapy. So that's the question from Dr. Vishnu Bhatt.
Right. So the answer to that will be that the initial studies, they used a single agent immunotherapy in multiple line failed treatment. So that was initial. And over the period of time, things have evolved and it has moved to the first line. So in the first line, for example, lung cancer, if you have if you have this PD-1 inhibitor, PDL1 in your tumor cell, then you can use this immunotherapy and it can be combined with chemotherapy. So this can be used as an induction, can be, and then followed by maintenance. So most of the immunotherapy needs to be followed up with maintenance. Now the question is, how long do we continue? So the current studies have shown that we need to continue till progression, but also there are data coming that maybe 1 year to keep the immune cells intact and probably eradicate the cancer. So the question is, how long will you give? Yeah, it's all evolving. Can be given as induction therapy. Maintenance, definitely 1 year is what is minimum, has to be continued indefinitely. The second other question was on what was the other question?
Okay. The other thing is, one more question is there, like the most fascinating example or the poster boy for immunotherapy was Jimmy Carter. At the age of 91 years, he responded to very widespread metastatic melanoma. So like we saw this was a success story. Similarly, do we have, do you use immunotherapy and cellular therapy as the first line for solid cancers, any other solid cancers, or when you only are using it as adjuvant for relapsed cases?
So, the adjuvant is basically, just for technical correction, that adjuvant we generally use only one if the tumor is curable. So you operate, remove the tumor, then you use as adjuvant. So currently, none of these immunotherapies have been used in adjuvant therapy. All this has been used in treatments.
Is it being used? Is it experimental?
Okay. So the stem cell therapy is otherwise called as the blood and marrow transplant. Now, what we call as a bone marrow transplant. So people should understand that there are two different parts of stem cell. One is a therapeutic stem cell approach for some malignancies like leukemias and lymphomas. Go ahead. It's not audible.
No, please go ahead. I think your audio got cut off in between. Yeah, please.
So the therapeutic stem cell, which is otherwise called the blood and the marrow, which was previously called as the bone marrow transplant, is very well no longer an experimental therapy and is approved therapy, which we routinely do in few malignancies like acute leukemias, in myelomas and lymphomas. So there are only particular malignancies where this particular stem cell therapy works. The other kind of stem cells which probably people get is from mesenchymal stem cells. You take out, derive, and then you inject them into, let's say, into the cardiac, or you inject them into some soft tissue area for development. Those things are experimental and still not proven. So therapeutic stem cells for hematologic malignancy, well proven and useful. And that's kind of.
Yeah. Thank you for taking that question. I think this would be the last question. What is the role of targeted therapy, immunotherapy in ovarian cancer post-surgery? That is from Dr. Shashikala, HOD OG.
Okay. So the immunotherapy in ovarian cancers have not taken off for some reason that they have not actually found very good responses in ovarian tumors. There are other targeted therapies which have come up, like the PARP inhibitors with respect to BRCA and the homologous recombinant deficiency related targets. That's a completely different target. It's not related to immunotherapy. Those are the things which are developing. Some of these monoclonal antibodies like bevacizumab was one which got an approval in ovarian cancer, but it's not a great drug, has not shown a dramatic kind of responses like what I have shown before. So apart from that, the immunotherapy as such, ovarian cancers are not being, there are studies have not actually shown very promising role. But other targeted therapies like the HRD blockers are definitely promising outcomes.
Okay. Thank you, Dr. Biswajit, for patiently answering all these questions which have been put forth by the audience. We really had a nice overview of immunotherapy today. You started tracing the functioning of immune system from the very beginning, and you spoke to us about various antigens, antibodies, how you can modify them and all that. You took us through the timeline of immunotherapy for each form of therapy and various therapies and their results. And you also shared with us the most important part, the side effects and when not to use this therapy. Thank you very much for sharing your expertise and knowledge with us. I thank you on behalf of all the participants and also on behalf of the Scientific Society of Aarupadai Veedu Medical College and the Vinayaka Mission Research Foundation. We'll hope to have you again with us in another session where we could explore some of things. Thank you very much. It was great having you.
Great pleasure, ma'am. Thank you. Thank you.
And for the participants, we have a small announcement. Right, we'll be back tomorrow with another session of lectures. That is, tomorrow we have a very apt and in-time topic. So we are going to explore the role of telemedicine during the COVID crisis. And JIPMER Pondicherry, as you all know, that has been doing a lot of work with regard to telemedicine in this current crisis. So we have with us Dr. Ravi Kumar Chitoria, who is the Professor of Plastic Surgery, and he also happens to be the Nodal Officer of Telemedicine in JIPMER, Pondicherry. So he is going to share with us his experiences on how telemedicine can work during this time and what is going to be the future of telemedicine in the country in the post-COVID era. The only difference is tomorrow's session will open at 9:30 in the morning and not at 3 o'clock in the afternoon, right? So we'd hope to see you again tomorrow with another interesting talk in our series on the forefront of future frontiers. This is Dr. Mahalakshmi, Dean Health Professions Education from Aarupadai Veedu Medical College, signing off on behalf of the Scientific Society. Good day, folks. Bye-bye.